Hey, welcome everybody. This is Bill Richland with Wound Care Gurus Live. Sorry for the technical difficulties. Don't know what happened. For some reason, my software platform was not streaming out. We started once, didn't work. Started twice, didn't work. Had to make some tweaks to it. So again, you have my sincerest of apologies. We have not had this issue yet. So this is the first time. So love techno must be 2021, our first Facebook Live, and everything is, typical craziness of 2020 has rolled right over into 2021. So again, welcome everybody. We're excited tonight. We've got a great interviewee. We also have some great information I want to share with you. Even before we get started, I just want to bring up some promotional stuff. Just a heads up that our advanced wound debridement, Sharp Debridement class schedule is up for the spring. You can see a number of locations all over the country: Tampa, Minneapolis, Philly, Salt Lake City, Kansas City, and Milwaukee. So if any of you are interested in getting your sharp debridement skills on, check us out at sharpdebridement.com, and you can get all the details right there at that website. All right. Another thing that we have is we've got an upcoming new webinar coming out on February 3rd. Antimicrobials, are you getting what you paid for? Seriously, folks, I'm going to be honest with you. If you are using antimicrobial products or dealing with people that are using antimicrobial products, this is a webinar you do not want to miss. We are going to actually go through all the different agents that are used in antimicrobial products in the industry today, and we're going to show you the evidence. How effective are they? Do they kill anything? Do they kill stuff in wounds? What does the evidence say? So this is a do not miss event. You can register now at woundcaregurus.com. We are taking registration. It's a free webinar, no charge. So come on in and join us. This is going to be an incredible opportunity. So with that being said, I don't know why my wife's name is coming up here because she is not me. But I want to bring up our guest for tonight. There he is. Our guest tonight is Dr. James Steele from Steel Tech. Welcome, Dr. Steele. How are you doing this evening?
Well, Bill.
Excellent.
Hope you're okay.
Yeah, I'm getting through it. I'm just rolling with it. It's 2021, and I guess I'm dragging some of that nuttiness in with me tonight with all my tech issues. But that's all right. I'm good with it. This is probably the most informal show that we do. I'm not here to tell anybody I'm a professional tech person. We don't have professional production costs. We're just winging it, having a good time, sharing information with our audience, and educating people in wound care. So, how is your day going? Better than mine, I hope?
I've been busy. I mentioned to you, I got another super stage 4 pelvic pressure injury in today that had 5 wounds.
Only 5, though. Only 5. Excellent. Well, that will definitely keep you busy. So, hey, why don't we get started since we're running a little bit behind with the tech delays? How about we start off, Jim, with you just telling us a little bit about yourself, your background, and what your role at Steel Tech is.
Well, I would start off by telling you that I would call myself a semi-retired orthopedic surgeon. I practiced about 36 years, and much of my practice life started out doing osteomyelitis at a major trauma center. And then I drifted into total joints, and because I was always interested in the hard cases, they shoved me the infected ones. So I've done over 250 infected total knees and total hips, which really gets me pretty deep into infectious disease and wounds and how wounds heal.
Sure.
But the other sideline I have had has been product development. I've worked on several computer navigation projects, and I've developed some surgical instruments. And I got particularly interested in fluid flow and those sorts of things about 10 or 12 years ago, such that when I kind of hung things up, I got back to working on those products.
Okay.
And I was working on an irrigation product that had suction, and I wanted to put a CO2 brush in it, and was kind of making my way. But in order to make something that I could actually produce and sell, I had to get something pretty simple.
Right.
And my old Pew rep told me, Jim, well, you need to look at wound care. And I said, well, I don't know. What are they doing in wound care? Well, they have to treat wounds, and there's washes and things like that are done. But, that's what I always thought you needed was washing of the wounds. So I immediately got into to that problem of how do you wash wounds in the outpatient wound clinic or SNF or wherever
Right.
setting. So that's what I did. Came up with a product where you could do wound care and basically do what I do as an operating surgeon in the outpatient setting.
So your primary reason then for developing the Perilav system, if I understand, is to come up with a better way, more efficient way to clean dirty wounds. Correct?
Yes, that's
Excellent.
it.
So in developing the Perilav system, which obviously we're talking about, that's your primary product right now, were there any challenges that you found when you were designing this system? Because it doesn't sound like it's just something you just stick a couple of tubes together and splash some water and squirt it into a wound. There's got to be a little more to it than that.
Well, I had to come up with a bag system that was number one simple, that was pretty cheap. I had to build durability into it, and that took quite a bit of time. I had to use a little thicker plastic than what other people have used.
Mm-hmm.
I had to come up with a method, and I ended up with an industrial grade impact sealer, and I double seal all of my junctions.
Okay.
And I wanted I wanted a product to do a couple things. I wanted it to be efficient and easy to use, kind of stupid simple if you want.
Sure.
But then my objective was to have an irrigation method where you could put 3 to 6 liters of saline on a wound
Right.
and not one drop would touch the bed sheet. And that was what I tried to do. And I think I got pretty darn close.
Mm-hmm.
Um, for the bag, for example, I've got a bag here.
Sure.
The way this thing is,
Yeah.
this is
Just
a very
hold them
simple
up right
bag.
in front of your face. That way we can see them the best. You cover your face
Yeah.
up, then it's right in the middle of the camera.
So there's the bag. That's the hole, and this is the whole length of the bag, as you can see. So it's pretty long. This thing will basically go down to the floor if you're in a bed at the hospital, or you can sit it on whatever you want.
Sure.
But you see what I've done there is this is kind of our first prototypes,
Uh-huh.
and this is all a double film ostomy tape. And I met the guy who's one of the vice presidents at Avery Dennison, and I told him I want a perfect, double film tape so that I can stick these onto the patient's body,
Right.
and they isolate the wound, and they don't pull off or whatever.
Sure.
And so he came up. Avery Dennison has been doing this for many years and spent
Uh-huh.
millions and millions of dollars to come up with the ostomy tape that they want. And he says, Doc, I got the best one. Of all the ones that we use here, I think this is the best one. So he sent a big roll of this stuff to me, and I take it off and cut these little strips off, as you can see. We now have a better way. We're actually making templates for this big square now that we know how big it is.
I think you sent me a picture too of the Perilav, didn't you? Be in action. I think I'm going to pull that up here quick.
Yeah. Oh yeah. So yeah. Here we go. This was one of my first cases that I did. You can see the physical therapist there. She has my irrigator that she's putting right up into the wound, and that bag that you see there is similar to the bag that I just showed you. But I'll tell you how I evolved it as we went forth in a minute. And that irrigator I buy, these are not terribly expensive, but you have to go through a process, and the vendor who sells it to me has to be registered with the FDA, that sort of thing. It's a sterile system. It's a marvelous irrigator. It's a kind of a prototype. It's kind of, I would call it a knockoff of the Zimmer Pulsivac. And what's nice about it is that they put the batteries in the handle, so you don't have to have a battery pack, which it really is ideal for what I want to do in outpatient care. Cool. But it's a really nice system. So this is what one of those irrigators looks like. And so there's no battery pack here. It's just this device. Uh-huh. And it has two little, one is slow, and the other, that's slow, and that's normal.
Gotcha.
And it works great.
And what kind of PSIs is that putting out then when you're using it?
Well, the healthcare quality assurance, I guess, committee of CMS basically told us that and this was a consensus back in those days, it was about 15, 20 years ago.
Mm.
They decided that 15 psi, if you had that as the top limit, there was hardly any potential risk of using those devices back in those days. So they resolved 15 psi as the rule, and the FDA accepted it as well.
Mm-hmm.
And here we are now, probably 20 years later, extraordinary success with that product. It gives you enough pressure to wash the wound off and get rid of most of the biofilm.
Mm-hmm.
And it's safe enough that you don't have to monitor the treatment. It can be done by nurses, it can be done by therapists, it can be done by PAs and, of course, physicians, residents, and
Sure.
that sort of thing can
Right.
do this treatment. But I've looked on the FDA website. There's just no examples of any complications doing this treatment.
Good.
So
I just want to say a quick thing to our viewing audience. If anybody has any questions for Dr. Steele, we're taking questions. Just type them into the comment section in your comments, and we will certainly field those questions as they come in. So what would you say are the primary indications for wound care in using your product, and what types of wounds? Are there any particular types it's better for than others, or kind of just give us a little background on that?
Well, there are two settings where I think it's really, really important. The first one would be early wound bed preparation.
Okay.
And this is a new wound that you might get into your clinic, or a patient who's had, a chronic wound's a wound that's over 3 months.
Sure.
But if that wound has stalled or isn't working or whatever, and then the basic criteria, if the wound, a lot of slough, a lot of drainage, a lot of smell, a lot of pain, they're problem cases.
Right.
This is how you fix it. You start washing with this, and I've done this so many times now. It's just methodical. If you start washing that wound, you get rid of the smell in about a day, and you get rid of the pain in about 4 to 5 days, and you get good granulation tissue probably within the first week or so. But that's where you want to be. So if you're a wound doc and you're doing some of these advanced products like Apligraph or a derm sub, or even what I like are these autologous skin products, where they culture skin cells, put them on a kind of a hydrogel membrane, and then put that on the wound.
Mm-hmm.
You've got to have a perfectly clean wound.
Right.
It has to be almost sterile, or sterile enough that the human body can make it sterile. Like your eyes are sterile because the tears and everything are antiseptic, and your eyes are clean.
Right.
So the point is, that's where your wound should be. I would say to wound providers out there, if you're looking at a wound in the clinic and it smells and it's got a lot of gray slough and it just looks nasty, you're doing something wrong. You shouldn't do that. They shouldn't be that way. They should be clean. And during your treatment, they should stay clean.
Right.
So for these difficult cases, the stage 4 pressure injuries I see, they are so difficult that we end up irrigating them 5 days a week. And we've tried numerous times to back down that treatment. And when we do, they start getting ischemic and necrotic. The little granulation tissue just dies, gets brown, and doesn't look good. And we get them back to normal, the nice red granulation appearance. But those are very suspect wounds, and they're not for a lot of treatments, just the simple stuff that a lot of our viewers here would use. You've got to really be aggressive with those wounds. Otherwise, the patients are going to get septic, and when they get septic, they die.
Sure.
So
well, that makes sense. Would you say that you can pretty much use this on any type of wound? There isn't any particular type of wound that it would not be appropriate for, as far as etiology goes?
I like it for the most difficult wounds, the ones that nobody else is able to deal with. Those are the perfect wounds, because I guarantee you I can make them better. Could it be used in the emergency room for somebody who comes in with a dog bite, or some road rash from falling off a bike or something? Absolutely, it's perfect for that as well. So that's a good setting. I have a friend over in St. Louis that wants to use it in the operating room because he wants to irrigate wounds. Back in the day, this is 15, 20 years ago, I had patients that had AIDS that I had to operate on. And I certainly did not want to use a pulse tie irrigator on a patient who had AIDS and aerosolize that fluid up into space, and I might be breathing it. So that's another indication. But for the difficult wounds, and I say that's for the bottom half that are really hard to handle, the chronic stalled wounds,
Right.
this system is optimal.
Oh, excellent, excellent. So, did you, as you were using your system over time, first developing it and then starting to use it, did you deal with any issue? Did it start dealing with wound issues that you didn't understand initially? That all of a sudden you're like, wow, this is also dealing with stuff I didn't expect it to?
Well, it kind of yes and no. I've done wounds like this for so many years that, when I treated a wound and as an orthopedic surgeon, if I cleaned up that wound, I expected to stay cleaned up. And but wounds that are external that got dressings on them that are open things, and if they're in the right situation where the wound's really infected, they aren't going to do that well.
Right.
So the one thing I learned was that this system will get rid of the infection. And I just published a paper in Advanced Skin and Wound Care a month ago. Oh, it's about 6 weeks ago now. And we were able to show how if you irrigate these really severe diabetic wounds where you're getting a lot of brown tissue, if you drive that inflammation off of that wound, and basically in the process you're driving off the biofilm bacteria,
Right.
those wounds do okay because the inflammatory stress of that wound dramatically drops. And now the body, the host can get onto what it really needs to do, and that's rebuilding the wound.
Right.
Bringing the fibroblasts and the macrophage, all that stuff comes into play, and you start building ground substance and tissue then that will become the healed wound.
Right.
And to get there, you've got to get that wound. The body has to do this. So the body does most of the work. You just keep it clean.
Right.
That's what you're doing.
Sure.
So if you're not keeping a wound clean, there's no way it's going to heal. It's just not.
Right. Right. Well, as I've always taught when I'm teaching my students, the two fundamentals to healing any wound is you have to have a healthy patient and you have to have a healthy wound environment. And if the wound environment is not clean, and it doesn't have to be necessarily a clean that you can see, because with biofilm, you can't see a biofilm. So even the unseen unclean is going to keep that wound from healing. So sounds like this is a great opportunity to make sure that you, as you said, keep it clean, and the wound can actually do what it needs to do, which is heal. Did you want to follow up on that?
Well, when I started doing this, I had to find cases to do, and the cases that I got were patients that nobody else wanted. So most of them have been stage 4 pelvic pressure injuries that are just disastrous. So now you got a bad wound in a bad patient in a difficult scenario. Mm-hmm. And it was a real challenge. And I figured if I could make it work there, it'd work anywhere. And I think I'm correct.
Right.
I think we've solved some real issues.
Excellent. Are there any specific contraindications for the use of your product with wounds?
Well, yes. For anybody, if you're going to be a surgeon and you're going to be looking at an artery or a vein or a nerve, or I guess a lot of wounds that we would see around the pelvis, deep bone, mm-hmm. you got to be a surgeon, because those are structures that you cannot damage.
Right.
For example, if there's an artery that's in the bottom of a wound, you can't go, if you're not a surgeon and you can't fix that artery in case something goes wrong, you don't want to go near it.
Right.
The same with nerves, the same with organs, like I don't do a lot. I haven't had much training in abdominal work, but I'm definitely going to get some abdominal wounds to treat.
Sure.
And if that wound goes through the fascia, and I'm looking at a loop of bowel there, I'm not comfortable with that. So that would be one that I wouldn't want to go near. So those are the ones that I would tell people to really steer clear. And most wounds are pretty superficial anyhow, so it's not a problem. But if you even suspect, and I'll show you the case that I'll show you in a minute, was a case that was a problem case, and it was a paraprosthetic joint infection that I discovered basically using the moleculite. Right. And that wound tracked down to the hip joint. And if I would have known it when I did it, I probably wouldn't have tried to irrigate the wound, but I found out in the process. So it worked out okay.
Good. So Darcy just made a comment, one of our viewers, about playing the video again of how the device works. We didn't really play any video. We showed a picture, but just do you have any videos up on your website that they can see it working?
Yes. If you go to my website, which is YouTube Steel Tech. I've made 2 or 3 videos on there that show you everything. I mean, you basically everything you need to know about this system. I made those YouTube videos about 2 years ago, and
Okay.
they were so accurate. I found a few, a bunch of innovations that I might want to talk about, but no new information really, except for the new products that I've built.
Okay, well, great, Darcy. So if you check out his YouTube, Steel Tech, and on the YouTube out there, you should be able to see some actual videos working. Let me move on to my next question. What kind of feedback have you gotten from your patients? Obviously, you're telling me all this cool stuff and great things that's happening. How do your patients feel about it?
Um, I hate to brag, but the patients absolutely love it. This guy I'm treating right now, and his case is going to show up in a publication that I've submitted. He has been treated for a really bad sacral injury for about 6-7 years. He has had all kinds of treatment. He has had wound vacs for years. He's never gotten over this infection. And I took him on about a year ago. I've got that wound about 80% closed. He has had no pain. He feels great. And he said all those years he was infected, he just didn't feel very good.
Right.
And he just basically concluded he was going to die from this problem there in the nursing home. That guy, we talked to him about a week and a half ago, and he says, you know what, this is the best I have felt in years. He said, I think I now have the potential of healing this wound. And he is ecstatic. Now, if he was the only guy that said that, I would say, well, maybe it's just, he's a one-off. But they all say it. They all pretty much find the treatment is very efficient. It takes minutes, you're irrigating, 1,000 cc's a minute with this irrigator. My new system goes 2,000 cc's a minute. So you're going to be done irrigating in about 3 minutes.
Right.
There's no pain if you push off the inflammation of a wound. The nerve sensitivity of the wounds just goes away. So we don't have any trouble putting pressure up to 15 psi on wounds for pain. It just doesn't work that way.
Sure.
And the patients just like the process. It's not hard to do. It doesn't take very long. They feel better. They see progress. What amazes me is the effect that I've had on these flaps and tunnels under these wounds. If you put this little tip on the wound, and then the new irrigator that I've created has got even better handle tip that you can get down into those recesses. Mm-hmm. Those things close up like almost by the day. I can show you some examples. I don't think you have them on my show tonight, but those tunnels will close up in 3 to 4 weeks, and these are big flaps under there. And it stands to reason you've got tissue over this space. If you get the space clean, get the biofilm and the bacteria washed off, that wound just sucks together. It's amazing.
Okay. Cool. That's great. Somebody's asking for the link to your video again. So is it youtube.com/SteelTech?
YouTube/SteelTech, STIHLTECH.
Okay.
And you'll get all you need to know.
Yeah. Okay. Yeah. I think if you just go to YouTube and probably go to the search and type in Steel Tech or Perilav, I would think that it would probably find those videos. But usually I think most YouTube addresses are youtube.com/ in this case, Steel Tech. So excellent. So how about, what everybody always wants to know with a product is there reimbursement available for your system?
Well, I had no idea about the finances of how this would go, and surgeons, we don't know what those numbers are. Nobody tells us. But getting into this business, I had to know exactly what those numbers were. Mm-hmm. And I've had some business training in the last couple of years, and I know you have to meet supply with demand. So those costs, whatever whatever the money is in the product, that's where you go. So what I've done is I've structured the kit fee, and that's all those components that I have in that kit, to match what CMS will pay you for the 97957 or the 97598 codes.
Gotcha.
So I'm at or below that number. So you can put your saline bag in there, and actually I think a pan of water is probably as good as saline. The literature would support that. It'd be kind of a off-label thing for me, but
Right.
I like that's what I would do. So we're to break even for the nursing homes.
Uh,
If you're a wound doc and you use this new pump that I've had, you're going to make a significant profit because our number then drops without this irrigator, which is kind of expensive.
okay.
So that's better. The wound clinics make a substantial amount of money with this technique in the wound clinic. So if you're doing your derm sub or whatever or in a wound clinic setting,
Uh-huh.
it's really it's good. It's very good, in fact.
Okay. Is it being used much in like home health yet at this point? Is it primarily long-term care and clinics for the most part?
I think the application of my system is for home health.
Okay.
I think the numbers are there to reimburse, but now it's just getting the home health agencies to get the therapists and the people to the really to the wound setting. And the other thing is that I think my new pump that you're going to show
Uh-huh.
will work perfectly for that setting.
Well,
Um,
that's a perfect thing. You brought up that. Are there, I was just going to ask next question. Are there any potential innovations that you are working
yes.
on? So let me pull that prototype up here.
Okay. This is a peristaltic pump. Peristaltic pumps are very, very commonly used in medical applications, like in cardiovascular surgery, for example, or any drug pump that you use is a peristaltic pump. It's just basically a simple roller pump. And so my son and I put this one together, and it's designed for simplicity. You only have one dial there. You've got one little green light that tells you on and off. You got a foot pedal, which is great for surgeons because surgeons love foot pedals. And it's low voltage. And the way we accomplish that, you see that little black box on the left there. That is a computer laptop charger, and basically that down steps the 110 or 220 to a 24 volt, which basically runs my peristaltic pump. So it's a very simple idea. The tube set's about 9 feet long, which we found is ideal for use in the nursing home. That handle I designed myself. That's a 3D printed prototype there. It's a little smaller for a lady's hand, and it's just perfectly set up to where you can stick that tip under a flap and irrigate a wound out. Otherwise, we use these long tips that we get for the irrigators. But that's it. That's what I have. And the spray is designed more as a fan spray, like you'd see in a car wash. In fact, the tips that I have, I got those tips and 3D printed them from a company that makes most of the car wash spray tips.
Okay.
So it's
Do
a
you have,
very efficient, very well designed spray that you're creating. You can spray all kinds of designs, but
Mhm.
just a little simple fan spray, I think, is going to be perfect for us.
Do you have
Um,
any examples of the tips you have for the Perilav system currently with you? Um,
I'd have to go get them. They're in another room, but
oh,
they're
okay.
just whatever.
It's all good. No worries. They can see them on your videos, I'm sure, or
Sure.
at your website. So, um, let me ask you this. How well does your system work with other innovative technologies? I know you're pioneering, so to speak, from our previous conversations of utilizing other advanced technologies that are new to the market in conjunction with your approach to wound care and your product. So could you talk a little bit about that?
Well, for my viewers, I am a medical scientist in addition to being a physician. And one of the things that I noted, because when I did really difficult total joint problems, incredibly difficult total joint problems, I would find any technology and all technologies that might help. And so what that meant was when I'd go into the operating room, I'm literally throwing the kitchen sink of potential treatment modalities at a wound problem.
Sure.
And I'm going to be a bit blunt here when I say this, but I come into the wound field and I see a lot of companies trying to push their product or their idea, and at the exception or exclusion of other products. And I don't like that because the cases that I'm dealing with now are extremely difficult, and
Mhm.
I'm lining up all the different technologies that I think I can find that are going to make a difference.
Sure.
So what I've learned already with these stage 4 pelvic pressure injuries, there's a new device on the market called the Moleculite. This is an autofluorescence imaging device. It's basically an iPhone that has a violet light on it. And all the it's an iPhone. So I mean,
Right.
I could call you tonight on my Moleculite because it's got Wi-Fi and everything. But so that's one product that I've picked up in the last 6 months. An extraordinary technology because now you can actually see the bacteria.
I think
So
you got me some cases to look at. You want to show some of those while we're on it?
sure, throw up one of those.
All right. Let's pop up one here.
So this is my guy that I started talking about. He ended up going to St. Louis University, about a year ago, and the 4 trauma guys at SLU operated on this guy for about 2 weeks. He ended up with a wound he was the guy that had it for 8 years. They 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 operated on him 4 times, and the wound measured 270 square centimeters. This picture here was back in June, and we were irrigating this guy every day, but he got some indigestion, and I think it was some med issues. So he went to the hospital, and he came back about 10 days later with a wound back on, and just didn't feel right. The wound looks okay to me, but he didn't feel well. We were getting some odor on the wound, and it had been really clean going for months and months. But I looked at that wound and I said, well, I don't know. I can't really tell. Bill, I don't know if what is this? Why is he getting sick? He, they had uh, put him on a blood thinner, Xarelto, because he had all kinds of things. That he had blood clots in his legs. He had an aortic stenosis. He had atrial fibrillation. So there's a reason to put on a blood thinner. But his wound was bleeding, so I wasn't able to irrigate the wound very well. We had to go down to the slow level of the irrigator, and then we couldn't irrigate all the 3 liters. And so the effect was he was getting a wound that was kind of going south. Well, then I moleculated it, which you can see on the right. And those red dots, that is active bacteria. And it's kind of all over that wound, but particularly on the wound edges and on the peri wound. So it was a dirty wound that was getting dirtier by the day. So I had to make a call because the guy I thought was going to get septic. So what we did was to take the patient off the Xarelto, and that allowed us to get back up to the 15 psi 3-liter irrigation, and it knocked this wound out in a hurry. And now we do that treatment. There might be a few little spots of that growth that comes back in 24 hours, but this wound is basically a nice healthy wound on the each day.
Excellent.
And it's so predictable. I mean, I check the wound at least once a week, but when I was doing that, I was checking it like 2 or 3 times a week just to make sure I knew what I was doing. But
Sure.
this technology will guide you and help you do the Perilav and make the Perilav a much more, in my view, sensible treatment.
Excellent. You had one more case I thought was really interesting too. I'm going to bring it up. You can kind of explain, what you did and how your product was helpful and beneficial in treating it.
Yes, this is a ischial wound, and it turns into a kind of a holy cow because I had debrided that wound about 3 days before you see the picture on the left. Literally over a weekend, that wound went south. And I go, wow, how could this be? And the lady got sick. She was getting septic, temperature elevation. She had a white count of 14, 15,000. And what I'm looking there is a not a very large wound that I had debrided clean 3 days before. Now you can see slough. Now you can see redness. That wound is expanding. And then I did the molecular, and I go, oh my God, that is grossly infected. And what's interesting to me, if you look at that wound, you see a ring around that skin edge. And I think that's where the wound had tunneled at that point. And you can see those edges where I think this is what it is, but there's red beyond what the wound is. So I opened that wound up basically at the bedside with just a simple sharp scalpel. cutting through that fascia, and I got a load of pus out of that wound. And immediately that lady got shipped to the emergency room, and they put her on Vanco for a couple of days and sent her back to me. And then you can see 2 weeks later what that wound looks like. I use the moleculite again, and what I'm able to do is basically determine the area of the tunneled spot there. And you can see it measures about 27 square centimeters. And what I've done is I've cleaned up the wound. I debrided it several times. I see a nice red wound base that's in that hole. You stick so what I do is take a Q-tip and sound the edges around the hole. And then I take a magic marker and just make a little dot trace around where I think it goes at the periphery. And that gives me a pretty good measurement of that wound. I haven't seen people do this. I'm sure if somebody else has tried this because it's pretty simple to do. But now I've got a pretty strong, accurate measurement of the tunneled area, but also can measure the planimetry of the wound, which the moleculite tell me is down to about 2 or 3% accuracy. So there you get the length and the width and the area of that wound.
Very nice. Very, very nice. So I guess my one last question, and of course, if anybody in the audience also have any other last questions, please put them in the comments for Dr. Steele, because he would love to take them if you have them. I know he's kind of done a really good job explaining everything, but if there's anything, shoot it in there. But I guess my last question as we kind of start coming to a close here, Doc, is why would a clinician choose your technology, the Perilav, over other irrigations products on the market? I mean, there's a bunch of them out there. Obviously, when I teach my Sharp Debridement course, I list off, I don't get into detail, but I just list off a number of examples of irrigation and pulse lavage systems that are on the market today. So people are just familiar with the names. I guess, and this is a chance for you to be a little bit selfish, and it's your product. Why would they choose your product over someone else's?
Well, the only advantage that I give is what I think is a little better designed bag. My bag is sterile, it's FDA approved, and I spent a lot of time making it as good as I could. I have nothing bad to say about those other companies that are selling CPIs because they're as good as mine. I mean, I think this is a very, very underappreciated technology that really should be a mainstay in treating modern wound care. It's going to do the early wound bed prep. It's going to get you to this where you can use advanced products.
Sure.
It's going to solve these extremely difficult cases, which I tend to get now every day, and someday I'll get tired of it and won't want to do them anymore. But the point is, I have no trouble dealing with these patients because I know I can fix them.
Right.
So if it's a CPI or if it's the Perilav system, I'm sorry, just go use it because you're going to like it. It's going to work. You might like mine a little better because it's a little, maybe a little fancier in certain regards.
Sure.
But I just want people to use this technology, whether mine or somebody else's. The other point that I wanted to make a while ago was that I throw everything at these wounds. So I've got the moleculite now that I throw in. I've got my Perilav system. I'm looking for an antiseptic that I can build into my product where I can drip the antiseptic on the wound. I want a surfactant that I can drip onto the wound. Now, the FDA will not let you put on those products under pressure. I mean, it's just, no. So you've got to have an irrigation system that allows you to do that. So I would tell you that's on my list of products to work on and create one day that we can use. And the other product that I've got some exposure to that's not on the market yet, it's a new idea. It's called a micro bubbler. And this is my friend June Kong at the University of Illinois in Champaign. That product will take off with one treatment, 99.999% of the biofilm. So with one treatment with his little product, which are these little crustacean, diatoms that he coats with manganese dioxide, and then he puts hydrogen peroxide, which the diatoms convert to oxygen, and they become little tiny missiles at the nano level. And they will absolutely clear all the debris off a wound. Well, the problem is now you got to have a product. You got to have something like mine that washes the diatoms off. You got to have some kind of an antiseptic that will keep the planktonic bacteria under control.
Right.
And that's really important. And, so you got to pressure wash it as well. So all that has to be done. And we're going to create a system that does that. Surfactants are great. This
Sure.
call for
Mhm.
P188, you can inject it into your veins. It's that safe. So,
Right.
the wound treaters are going to see these mechanical products that are really going to help them in the future.
Right. Excellent. Terrific, Doc. Well, I want to thank you so much. I did want to put up your contact information because I know that some people are going to have questions. So if anybody needs to reach Dr. Steele, this is his information. He's got his number up, and you can email him, or obviously, reach him through his website. So I would encourage you guys, if this is something that you'd like to learn a lot more about. I mean, I met Dr. Steele. Oh, it's probably been a couple of years ago at a conference. I stopped by his booth. My wife and I did, and we're very, intrigued with his product, and we've kind of kept running into each other, and we end up talking to each other. And I thought, I think he would be a great person to come on and interview, and share this great technology that he's developing. I'm kind of excited about your prototype as well too. As you get that further developed to where it's fully marketable out there, I think that's going to make a huge impact in the industry, and that's it. And that's what it's all about. Wound care is about innovation and finding a better mousetrap. I'm all for that as long as it works and it produces good clinical evidence of its benefits. Then I don't see no reason why we don't continue to push the envelope to find out what we can do to heal these wounds in a faster, more effective way. So
thanks, Bill.
Yeah, but I appreciate you. Thanks for coming on, Doc. I'm gonna sign you off for now. So again, that we appreciate, the audience appreciates it, and
Thank you very much.
We'll be in touch soon. We'll talk again soon, Doc. You have a great night.
Thank you.
Bye-bye. Hey, everybody. I'm just gonna kind of wrap things up here with a few last minute things. I hope you enjoyed that interview and the information Dr. Steele had to share. I do want to give you our upcoming Facebook Live event. Will be coming out on January 28th, 2021. And just understand that it's called Is the Wound Really Infected? And I just want to say that it's by Dr. Miguel Mora, who is an infectious disease specialist. And it's going to be a great interview. I got to meet him at a course that I taught, and we struck up a conversation. He's a very, very brilliant physician in the area of infectious disease. And that's going to be our next topic coming up in, I believe, 2 weeks from now. So I hope you will all tune in for that. So with that, I just want to say good night to everybody. Thanks again for tuning in, and you all have a wonderful weekend.